My name is Steve Anderson. This is course MSES 34, The Essentials of Trauma Imaging, and please remember to fill out your assessment forms of this course. So I'll spend the next 30 minutes or so discussing CT techniques in trauma imaging. And what I'd like to cover is a discussion initially about CT scan acquisition, talk about the use of oral and IV contrast in trauma imaging, talk briefly about radiation considerations before moving into three distinct areas. Firstly, arterial phase abdominal imaging, and present some data that there may be some added value to this practice. Talk about pelvic CT angiography as well as extremity CT angiography and their use in trauma imaging. At our institution, we routinely use 100 milliliters of intravenous contrast, 370 milligrams per milliliter, injected at a fairly high rate. And we usually use routine delays for our bolus timing, for our IV contrast bolus timing, unless we're integrating extremity CT angiography. And I'll go into this in a little bit more detail in those specific sections. But we use a routine delay of 30 seconds for our chest and upper abdominal imaging, a 70-second delay for the conventional portal venous phase of the abdomen and pelvis. When we're integrating pelvic CT angiography, we use a standard delay of 25 seconds. And as I said, when we're integrating extremity CT angiography, we use a timing bolus technique. And when appropriate, at the discretion of either one of our residents or attending staff members who's sitting at the scanner looking at the initial images, we'll make a decision about whether or not a 5-minute delayed phase acquisition is indicated. And if indicated clinically, we can add a CT cystogram during that 5-minute delayed phase acquisition. We don't administer positive oral contrast material for our blunt trauma patients. We do, however, administer both oral and rectal contrast material for our penetrating trauma patients, which along with our IV contrast makes up the so-called triple contrast protocol. And there is some data, some evidence to support this practice of ours. CT without oral contrast material in the blunt trauma population has been reported to be appropriate for identifying surgically relevant blunt bowel and mesenteric injuries. As far as the triple contrast protocol in penetrating trauma, its accuracy has been reported to be appropriate for identifying both peritoneal violation and visceral injury. A recent survey that I thought was interesting, it's the last reference here on the slide, about a quarter of academic ER that were surveyed, and this was a fairly large survey, about 150 academic centers, about a quarter use oral contrast in blunt trauma. Not particularly surprising. What's more surprising to me is the relatively low use of oral and really low use of rectal contrast in the penetrating trauma population. There's no evidence to support the absence of those agents in the penetrating trauma population, and some pretty good evidence to support its use. And here's just one example of a patient that was imaged after penetrating trauma, in which we do have secondary evidence of a hollow visceral organ injury as evidenced by this extraluminal contrast material. And in this case, an added benefit of actually identifying the rent within the distal colon. What we actually put onto PACS is, obviously after the scout topogram, we're reconstructing our chest acquisitions in both 1.25 and 2.5 millimeter data sets, and routinely processing both coronal and sagittal reformations 2.5 by 2.5 millimeters. For our conventional abdominopelvic imaging, we're reconstructing both at 1.25 and 3.75 millimeter axial data sets, and again, the standard 2.5 by 2.5 in coronal and sagittal planes. As far as our radiation settings, for our conventional chest CTs, as well as our portal venous phase abdomen pelvis, if you're familiar with the noise index of GE, we're using a 23. We use also a lowering of the maximum MAS that these machines can output to a 650. For our delayed phase of the abdomen pelvis, very importantly, we can lower the dose fairly significantly. In GE parlance, increase the noise index to 27. That translates to a dose reduction of about 20 to 30%. For CT angiography of the pelvis or the extremities, also important, we can also lower the dose there. We have an inherently high contrast to noise in that angiography, and we can get away with a little bit more noise. Again, about a 20 to 30% dose reduction when compared to our standard radiation settings. And if you're familiar with noise indices, those are based in our institution on the thinnest data set that we're reconstructing. And in all cases, we're using an iterative reconstruction tool, and we're setting that to 40%. Let's move on and discuss for a few moments the application of arterial phase abdominal imaging in the trauma population. What we're doing now routinely is extending our chest acquisition, and as I said, that's a 30-second routine delay, extending that acquisition through the abdomen to the level of the iliac crests. Downside being obviously added radiation, but there is some evidence that there is a significant upside in splenic trauma. Two recent publications, the top one is from our group, demonstrating that the majority of contained vascular injuries, the majority, are only identified on the arterial phase of image acquisition. And from our series, 50% of those contained vascular injuries that required intervention were only identified on that early phase of image acquisition. So some good reasons to do that. Let me show you some examples. Arterial phase through the spleen, we see this contrast blush, which in this case, fortunately, is also fairly visible on the portal venous phase of image acquisition. And again, this will happen in the minority of cases that we can see these injuries during the portal venous phase of image acquisition. And as expected, during the delayed phase, this completely washes out. Let me show you the examples of injuries that are only seen on the early phase. Contained vascular injury, 30-second delay through the chest and abdomen. We clearly see this injury. And on the portal venous phase, I'd argue that it's very difficult, if not impossible, to identify this injury. There's obviously a large laceration, but the contained vascular injury, very subtle. Another case to highlight this point, arterial phase, 2 images during the same phase, same patient, and we see multiple small contained vascular injuries, which are, in this case, really only identified during that early arterial phase of image acquisition. If we think about the other major injury of the spleen, active hemorrhage, or arterial hemorrhage in this case, we see on the arterial phase active extravasation of contrast, which on the portal venous phase, as expected, continues to enlarge, and yet again, continued enlargement on the delayed phase. As far as any added value in active hemorrhage, there doesn't seem to be any. So we're really talking about contained vascular injuries of the spleen. And as far as any good evidence for added value of any other organs in the abdomen, to my knowledge, there isn't any, but those are really, we're getting those for free if we're going to decide to image through the spleen. So that's something you should consider. There is some evidence to suggest that there is added value of that practice. Let's move on to discuss pelvic CT angiography in trauma. And why should we consider this practice? It provides a rapid detection of arterial injury and identifies the sources of hemorrhage in this patient population. And maybe importantly for management in these injuries is that it may effectively differentiate between significant active arterial and venous hemorrhage. And it will help us predict the urgency of the need for DSA and embolization. We know that there is major bleeding in about 40% of patients with significant pelvic fractures, and that the management differs based on the source of that hemorrhage. When the hemorrhage originates from the bony injuries themselves or venous injuries, those patients are typically treated fairly effectively with external fixation. However, when the hemorrhage originates from an arterial source, that response to fixation is less predictable, and those patients often require embolization, transcatheter embolization. So at our institution currently, anybody with a displaced pelvic fracture on their admission portable pelvic radiograph, and of course this is ultimately at the discretion of our trauma surgeons, and based on things like hemodynamic status and mechanism of trauma, but it includes nearly all of the patients that have pelvic fractures on their radiographs, we acquire a pelvic CTA. And those are readily integrated with a single initial intravenous injection of contrast into the rest of the patient's imaging needs, whether it be CT chest, abdomen, pelvis, or even integrated with an additional extremity CTA. In this case, we're going to put the very thin data sets onto the PACS, 0.625 millimeters, and we've experimented with 2 approaches to bolus timing, either the timing bolus technique in which there's a small initial test injection, or the empiric 25-second delay. And the latter seems to work very well, and that's what we are currently practicing, a standard delay of 25 seconds, and the overwhelming majority of patients will give us a very high-quality pelvic CT angiography. Let me show you some cases. Arterial phase pelvic CTA. This is the most common injury that we're identifying in these patients, and that is active hemorrhage. And we see that, as expected, by the portal venous phase enlarging, and on the delayed phase, yet again enlarging and somewhat more diffuse. This patient was successfully managed with embolization given ongoing arterial hemorrhage. Another case, similar injury on the contralateral side, again, really significant. This is a significant amount of extravasation at 25 seconds after contrast injection. And you can see that enlarge on the portal venous phase. And this patient also successfully treated for several sources of ongoing active arterial hemorrhage. This case highlights the capacity for us to differentiate between the sources of hemorrhage. Same patient, two different phases, arterial phase in the upper row, in which we don't see any evidence of active hemorrhage. The portal venous phase in the lower row, and there is evidence of active hemorrhage in the region of the presacral space. And I would argue that if I only gave you this portal venous phase acquisition, you would have a hard time being very confident that this is only a venous hemorrhage. And you may send this patient to conventional angiography and turn up with a negative result. So this may be used to triage these patients and potentially decrease the rate of negative conventional angiography. Another example of the second most common injury that we see in this examination, that is an occlusion, and you can see that the internal iliac artery in this example is occluded. And those are treated very similar to the presence of an active hemorrhage, and that is relatively urgent embolization to mitigate the potential of any future hemorrhage originating from this injured vessel. Another example, one artery on the right, two arteries on the left, so we're missing something on the right-hand side, and you can see that in this case we're missing an anterior branch of the internal iliac artery. Same treatment, relatively urgent embolization to mitigate any potential hemorrhage. An example of a relatively rare injury, the intimal injury, in which we see a small amount of intraluminal clot, also very well seen on a volume rendered image and then on the DSA image. I would argue that this may be fairly subtle to see on a portal venous phase acquisition, in which there's less contrast between the iodinated blood pool and this little filling defect. Fortunately, this injury pattern is quite rare in pelvic trauma. Let's move on and discuss the use of extremity CT angiography in trauma. And why should we consider the use of this technology for this patient population? Well, we know that the majority of angiograms are negative. CTA is rapid, non-invasive, and we can image both lower extremities or upper extremities if necessary simultaneously. And the findings are known, very importantly, known to be sufficient to guide management. So we can manage these patients, triage these patients appropriately based on the findings at CT angiography. And then in addition, we can evaluate the rest of the patient in the multi-trauma setting. Compared to DSA, CTA is obviously less invasive, it's more time efficient, it's readily available, and we can detect some associated injuries within these extremities that may be clinically relevant and have some implications for management. Soft tissue injuries, bony injuries, maybe venous injuries. I'll show you an example of that momentarily. Some examples of extremity CT angiograms. This is a patient that suffered penetrating trauma to the forearm, and you can see a small pseudoaneurysm or active hemorrhage originating from the ulnar artery, short segment of occlusion, distal reconstitution at the level of the wrist. This is the processing artifact. The radial artery was in fact quite normal, but you can see a very high quality in this patient's extremity CT angiogram, and this is sufficient to guide management, very importantly. Another example, this type of skin surface rendering we find useful in the penetrating trauma population to focus our attention to the areas in and about the entry or exit wounds. When we're dealing with data sets that have multiple thousands of images, any techniques to save some time are definitely welcome. So we can kind of virtually dissect this patient's thigh, looking for the injury, and as expected, it's in the region of that entry or exit wound, and you can see a small occlusion, active hemorrhage originating from this patient's SFA, and the bullet present within the contralateral lower extremity. Another nice example of entry or exit wound within the medial thigh, and we can dissect into the iodinated structures here, and as expected, again, we have an injury, an occlusion of the SFA, active hemorrhage in the location that we would have predicted in this penetrating trauma. This patient suffered multiple gunshot wounds and required pelvic CT angiography in addition to extremity CT angiography, so you can see that the coverage was extended to include the pelvis. Also note the presence of positive oral contrast agent, positive rectal contrast agent in this triple contrast examination, and this patient also suffered an injury to the SFA on the left side. You can see a focal area of narrowing of that vessel. This is an example of a patient that suffered really significant soft tissue injury of the thigh. The CT angiogram of the arterial phase acquisition is totally normal, high quality as you can see. And due to the fact that the patient suffered such severe injury to the soft tissues of the left thigh, our surgical colleagues were quite concerned that this patient may have suffered a venous injury, and therefore suggested that we do a CT venogram. So after the arterial phase acquisition and imaging the rest of the patient's torso, etc., we imaged the patient's lower extremity with a 2-minute delay. And if we look at this CT venogram, it's never quite as pretty as a CT angiogram. The contrast is obviously more dilute during this phase, but we can see that the superficial femoral vein in this example, what should be this blue structure abutting this superficial femoral artery, is absent in the left thigh. And you can compare that to the normal side, the contralateral thigh, and this is definitely a surgical lesion. These types of venous injuries definitely need some kind of direct management. So when are we doing CTA? We consider this the initial diagnostic study if immediate surgery is not indicated and the patient has a diminished pulse, a large non-expanding hematoma, excessive bleeding, focal neurologic deficits. But I'll say that these indications have really evolved broadly at our institution, and we're applying extremity CTA really liberally. There's not much of a downside to doing this in the extremities. Our technique for lower extremity CTA, again, we're putting the very thin data set onto the PACS, the 0.625 thickness. For lower extremity CT angiography, we should be imaging both extremities simultaneously, even when only one limb is injured. We have that normal for comparison if needed. We're imaging from the joint proximal to the joint distal to the injury. If we're doing isolated extremity angiography, we'll inject 60 milliliters of IV contrast. When we're integrating it into the torso acquisitions, then we're going to inject our conventional 100 milliliters, and again at a fairly high rate. And we have one of 3 choices for timing these boluses, and we've experimented with all 3 of these and ultimately decided to use the relatively time-intensive timing bolus technique, in which we inject a test injection of 20 milliliters and really rigorously evaluate the kinetics of that bolus in order to ensure optimal quality. I'll show you, this is an example of a very normal CT angiogram, high quality, through the joint proximal to the joint distal to the patient's penetrating trauma. And in contradistinction, this was a technically fairly poor examination. At the level of the pelvis, everything looks very good, nice enhancement. This is a routine delay of 25 seconds. And by the time we hit the level of the knees, you can see we've outrun the bolus. These machines move faster in the z-axis than the iodinated blood is able to travel. So this is one of the risks we run in doing large z-axis coverage of the extremities, and why we felt it necessary to spend the extra time to do timing bolus techniques. As far as upper extremity CTA, it's definitely a little bit more challenging than imaging the legs. In general, there's less experience in the field, And we're using a similar approach, joint proximal to joint distal. You have much more flexibility in positioning. Arms down by the side, when necessary, definitely works. There's less motion, but there's more significant image degradation. Or when possible, I think the optimal technique is to have one or both arms above the head. That creates significantly less noise. But in the multi-trauma population, that in some cases may be quite difficult. Again, timing bolus technique, very thin data sets onto packs, and we've demonstrated that this approach gives us very adequate technical quality in all cases of upper extremity trauma. Just an example of the types of folks that probably don't deserve to have CT angiography, with a lot of metal artifact in the soft tissues, significant image degradation. Thankfully, the resident did try to scan this patient for teaching purposes anyway. And we see a non-diagnostic, basically, CT angiogram. The pretest probability of injury is so high that this patient probably deserves conventional angiography in an OR setting. Another nice example of an arm above the head. This is really optimal technique if we can do it, and we see an injury to the radial artery in this example. The so-called Superman position, prone, arms above both arms above the head. In this case, it works out very well because the patient has penetrating trauma to both upper extremities. A very stable position, but in the multi-trauma population, very difficult to achieve. So we reserve this for the isolated upper extremity trauma. This is a nice example in which we have a comparison, arm down by the side and then arm above. You can see the patient was originally imaged arm down by the side. The patient has left-sided penetrating trauma. And in retrospect, the injury is actually quite apparent. The proximal vasculature of the arm is, in fact, very obviously injured. Fortunately, this was missed. Fortunately for teaching purposes, this was missed during the middle of the night, and an attempt at re-imaging this patient with the arm above the head, given ongoing clinical suspicion of an injury, was performed. And it's a nice demonstration of the differences in quality. Now you can see the arm above the head, and you can see the difference in image quality compared to the other position. And the injury, again, quite obvious in this case. In patients that deserve both extremity CT angiography as well as torso imaging, which is many of our multi-trauma patients, we can readily integrate these examinations. And it does require whole-body scout topograms for subsequent planning of these studies. And again, we're using timing bolus technique. And then we acquire the extremity CTA, appropriately timed using that test injection. And immediately after we're completed the imaging of that extremity, we go up and begin the imaging of the chest and our upper abdomen. So that happens somewhere around 30 seconds, definitely in an appropriate arterial phase. And then we'll wait until 70 seconds and do our conventional portal venous phase acquisition of the abdomen pelvis. And this is a scout topogram and a patient that was requiring this type of integrated imaging. And you can see timing bolus of the lower extremity in this case. So immediately after this acquisition, we're going to jump back up to the chest and upper abdomen in this case at about 30 seconds, and then wait and image our conventional abdominopelvic portal venous phase. So the advantage of that integration obviously is efficiency, and that's critical in this patient population. It also allows us to use that single initial 100 milliliters of intravenous contrast, and we've also reported that that's quite technically feasible, and we have very appropriate image quality of those extremity angiograms. Some examples of patients with integrated extremity angiography and torso imaging, whole body scout topogram, and you can see the extremity CTA in this patient that suffered really significant blunt soft tissue trauma. And you can see just really active leak of contrast throughout much of this patient's soft tissues. In this case, a fatal injury, very difficult to treat. Another example, this patient suffered chest, pelvic, and distal lower extremity trauma, blunt trauma in this case. And you can see selected images, pelvic CT angiogram, high quality, portal venous phase abdominal pelvic imaging, and the integrated lower extremity angiogram. You can see the significant soft tissue injuries. And if we zoom up into the extremity CTA images, you can see a significant bony trauma as well as occlusion or absence of contrast within the distal lower extremity vessels in this case. So in conclusion, I think that attention to technique in trauma imaging is really mandatory for us to be able to maximize the utility of CT for this patient population. There are some contrast considerations to be aware of, including IV contrast timing. You should consider the use of oral and rectal contrast, especially in the penetrating trauma population. Be aware of some radiation sparing approaches, and consider the appropriate use of this multiphasic imaging approach. Think about using arterial phase imaging of the abdomen, at least for select patients, the more severely injured multi-trauma population, and think about the integration of pelvic and extremity CTA. It's readily done with these newer generations of CT machines. So with that, I thank you for your attention.
Okay, good afternoon, ladies and gentlemen. It's tough for me, sandwiched between two such rock stars of trauma imaging, such as Jorge and Steve here, but I'm going to try and keep your attention now for about 25 minutes or so. And I'm going to discuss mostly hepatic, splenic, and we'll touch on some renal trauma towards the end. Now, one of the things that's often understood, but very often unsaid, is who we should be imaging in trauma patients. And it's one of those things that you have to actually think about. It's a bit philosophical, I know, but the patients we should be imaging are hemodynamically stable patients. We should not be imaging hemodynamically unstable patients. Now, we're pushing the envelope more and more as scanners are getting faster and we're getting more and more information from our imaging that benefits surgeons. So we're starting to image patients more and more who maybe 5 or 6 years ago would not be imaged. But I think it's fair to say that anybody who can't maintain a systolic blood pressure of about, say, 90 millimeters of mercury, despite aggressive resuscitation, probably shouldn't be on your CT scanner. So just remember that. We're imaging, particularly in these abdominal cases, patients who are hemodynamically stable. And without getting too philosophical, we also have to consider, why do we image in trauma? And unlike a lot of diagnostic imaging, when you're imaging to find a cause for abdominal pain or presence or absence of a pulmonary embolism, with trauma, the diagnosis is very often not in dispute. I mean, if you've got hematuria, you can suspect a renal image or a renal injury. If you've got left-sided flank pain and hypotensive, you're almost certainly going to have a splenic injury. But the reason we're imaging primarily in trauma is to triage the patients for further management. One of the further management options are supportive measures, such as fluids, antibiotics, etc., or patients going for interventional radiology for embolization of bleeding sources, or alternatively patients going to the operating theatre. The other reason we're imaging in trauma is to localize the injury to optimize surgical management. We're also imaging in order to diagnose early and in many cases attempt to predict those patients that may develop complications with resultant morbidity, such as bile leaks or ureteric injury. Another sort of thought process that I'd like you to sort of maybe consider is also in terms of imaging trauma. We conventionally think of this in terms of organ-based, such as liver imaging, spleen injury, pancreatic injury, bowel injury, etc. But CTA, as Steve has just shown, really has taken over trauma imaging. And trauma imaging is now really all about the vessels. So liver injury is not about injury to the liver, it's about injury to the vessels within the liver. You don't tend to die because your hepatocytes pack in. You die because you've bled to death. And this is what I want you to sort of think of in terms of trauma imaging. Think of it in terms of vascular injury, whether it's in the liver, the spleen, the mesentery, or peripheral vessels. Now, you're all probably very familiar with the AAST organ grading system, but it's been well established at this stage that these grading systems are of very limited value. I mean, they were great in their day when imaging was relatively poor. It would give you something to hang your hat on in terms of patient management. But there's a lot of limitations with the AAST organ grading systems, and principally among this is that it does not take into account vascular imaging or vascular injury, and it doesn't take into account things like bile leaks. So you can have a sort of a large laceration with minimal vascular injury, which would be a high grade but less severe injury than a small laceration that's resulted in vascular injury. And it's also quite difficult to classify grades. It's easy to differentiate grade 1 from grade 4 or 5, but it's difficult, say, to differentiate between grade 3 and 4 and 4 and 5. And if you're going to hang your hat on management based on these grading systems, then they have to be easy to get people into the correct grade. So as a result, these things are effectively no longer used. Now, having said that we're going to look at everything in terms of vascular injury, it does help us to sort of hang our hats again on splitting things into organ-based things. So we're going to look at the liver first. And as any surgeon will tell you, almost 90% of hepatic injuries have stopped bleeding at the time of theatre. Alternatively, about 67% of operations performed for blunt abdominal trauma are non-therapeutic. Now, these statistics date from about 2008, which is just around the time we were starting to get aggressively into CT angiography imaging. So it would be very interesting to see if they'd publish these figures further and see if these have changed. But these are the most recent data that they have available. And in terms of hepatic trauma, we like to look at it in terms of those things that will kill you and those things that will result in mortality. And it's vascular injury that will kill you, whether it's injury to the hepatic arteries, hepatic veins, portal veins, or IVC. Morbidity results from biliary injury to the bile ducts and the gallbladder. And when you're thinking in terms of vascular injury in the liver, there are really two things you're looking for. You're looking for active extravasation of contrast, and you're looking for contained vascular injury. So they're the things you want to identify, they're the things you want to not miss, and they're the things you want to differentiate between. And the reason you need to differentiate between them is because for the most part, management will tend to vary between these. Contained vascular injuries in the liver will be treated with embolization, whereas active extravasation can be treated either with embolization or with surgery, depending on the severity. And if you've got pooled contrast in your peritoneum, this is indicating a massive bleed, and these are the sort of patients that will tend to head on towards the operating room. Whereas if you have a relatively intact hepatic capsule, it'll indicate a sort of a self-limiting hemorrhage that can be treated by endovascular embolization. So here we have a sort of an example here where you have a fairly sizable injury to the right lobe of the liver, and you can see some contrast enhancement here. This is active extravasation of contrast, and the delayed scan at 5 minutes shows that this area of abnormality has increased in size, it's changed its morphology. This is active extravasation. Similarly, we have a little area of abnormality just in here in the porta hepatis, an area of active extravasation from the left hepatic artery. This area here is acute hematoma. This is not hepatic parenchyma. This patient went to the OR for operative repair of a lacerated left hepatic artery. Similarly, we have a patient here with quite marked contrast extravasation throughout large parts of the liver. And you can see here we've got some fresh hematoma in the right paracolic gutter along here. And this is evidence of active, massive contrast extravasation. This patient requires the operating room, and this patient had OR for right hepatectomy. On the other hand, you can have fairly significant contrast extravasation, as you have here, Overall, for the most part, the liver capsule is intact here, probably a little defect up top maybe, but something like this in a patient who's reasonably stable, this could be managed primarily by embolization, as happened in this case. You can see evidence of active extravasation at embolization. The patient was embolized with the coils here, and the post-procedural imaging shows that the extravasation has resolved. Similarly, in this particular patient, again, we've got areas of active extravasation. It looks reasonably contained. You've got a contained laceration here with active extravasation, again, contained within the hepatic parenchyma. Again, assuming the patient isn't in extremis, this is a patient who will benefit from potential embolization. And you can see here, again, some active extravasation on the embolization procedure. And again, following the coils, no evidence of active extravasation following the procedure. So some thoughts in terms of hepatic injury when it comes to the vessels. You've got to think of, first of all, define or make sure you're imaging only hemodynamically stable people versus hemodynamically unstable. When you are, and you have documented a hepatic injury, you're looking for vascular injury. You're looking for either active extravasation or contained vascular injury. And active extravasation can either be treated with either embolization or the operating room. Contained vascular injury will be embolized. If we switch over to the morbidity that you associate with hepatic trauma, this will come from injury to the bile ducts and the gallbladder. And you're going to end up with bile leaks, and you can divide these into free intraperitoneal bile leaks and contained bile leaks or bilomas. And free intrahepatic bile leaks increase your patient morbidity, increase your length of hospital stay, increase the number of subsequent imaging procedures and investigations the patients have, and increase the number of interventional radiology procedures the patient will undergo. And that's demonstrated clearly in this graph published by Fleming et al. And you can see here in red is the free intraperitoneal leak, and the massive increase in length of hospital stay, number of invasive procedures, and mean number of follow-up studies relative to patients with no bile leak or even a contained biloma. So identifying free intraperitoneal bile leak becomes important. And again, the AAST grading system does not predict the presence of a bile leak based on grade, and biliary injuries are associated with a high morbidity, particularly if the diagnosis is delayed. And Lebedes and al. Have found that bile leaks occur in up to 28% of patients who sustain hepatic lacerations. So you should think about bile leaks anytime you see patients with a hepatic laceration. Consider a HIDA scan. As I say, there's a high rate of bile injury associated with liver lacerations. And how do you detect them? Of course, HIDA scans are probably the easiest way to do it. You're not going to do this in the obviously day one in the trauma setting. The alternative is an ERCP. Obviously, it's a little bit more invasive in terms of invasion into the patient, but you do have the option of treatment at the same time by placement of CBD stent to treat the bile leak if you know there is a bile leak there, particularly if there's free intraperitoneal leak. CT can certainly suggest a bile leak, but it would require a diagnostic aspiration to actually prove it. An MRI, of course, is very little use in the immediate trauma setting. But using some of the hepatobiliary agents can identify some bile leaks following the patient's stabilization. And you can see example here in a patient who sustained a laceration to the left lobe of the liver. You can see the fluid signal on the T2 weighted sequence, and on the pre and post hepatobiliary phase imaging with EOVIST, you can see the contrast enhancement leaking out into the laceration, suggesting there's a small bile leak here in a biloma. Of course, the size of the laceration bears no relationship to the presence or absence of a bile leak, either biloma or free intraperitoneal leak. A large hematoma here in the liver with a tiny contained biloma. Similarly, another laceration across the liver here, and you can see there's multiple small bilomas present within the liver parenchyma, and in addition, there's some bile leaking out into the intraperitoneal area along here. Alternatively, you can use ERCP to identify these things. Again, another relatively small laceration, ERCP showing free intraperitoneal leak treated by placement of a CBD stent. Bile leak detection may require both a combination of a HIDA scan and ERCP on occasion. And we can see here a patient with obviously trauma to the superior aspect of the liver, clear active extravasation of contrast here, so that's going to require embolization to start with. A HIDA scan with delayed imaging shows there's some abnormality near the dome of the diaphragm here, suggesting some biliary injury. But the ERCP clearly shows evidence of free intraperitoneal leak here. And you can see this has been performed subsequent to the patient getting the embolization for the laceration to the renal artery. Another example of a bile duct laceration extending through to the branch of the right bile duct. Again, ERCP here clearly showing the extravasation, the HIDA scan showing the presence of biomas. Now, we didn't do a delayed imaging on this, which would actually be interesting to see if there would have been evidence of a leak on delayed imaging, because you should always really do a delayed imaging on your HIDA, because delayed leaks can certainly occur, as in a case like this, where we have another laceration through the liver, photopenic area here representing a large hematoma, and there's a biloma tucked in here as a result of that, but delayed imaging shows a leak into the right paracolic gutter on your HIDA scan. So it's always important to take delayed imaging if you are looking for bile leaks to ensure a biloma doesn't become a free intraperitoneal leak. Another thing to remember if you're looking for bile leaks is anytime you have an injury near the dome of the diaphragm that might involve the diaphragm itself, always consider the fact that you may end up with a leak through the diaphragm into the chest, and you may end up with a biloma within the thorax, which will require drainage. Similarly, another patient here with multiple sort of small liver lacerations and hematomas. 6 days later, the patient got significantly unwell, and you can see much increased fluid here tracking down into the paracolic gutter. This patient also had a bile leak, which extended up through the dome of the diaphragm into the chest as well. So a few thoughts on biliary injuries. You've got to consider contained bilomas versus free intraperitoneal leak and differentiate between the two. And free bile leaks are independent of any injury grade sustained to the liver. Always consider the fact that if you've got a biliary injury, delayed bile leaks can occur, so extend your HIDA out further. And think of intrathoracic leaks are not uncommon if there is a diaphragmatic injury. Consider early use of imaging to detect suspected leaks, because you may decrease patient mortality or morbidity by treating these early. If we move over to the spleen, and to say, well, the spleen is probably the most commonly injured organ in the abdomen. And again, there is a grading system of injuries available. It's again of very limited use in terms of triaging patients for further management. And again, we're imaging in the spleen to predict the outcome and guide patient management, again between conservative therapy, embolization, or operative therapy. Again, the sort of CT findings in the spleen, multiple hematomas, lacerations, fractures, shattered spleen. None of this really matters in the absence of pure vascular injury. You can see we have a variety of splenic injuries here, but unless you're actually identifying a contained vascular injury or a free active extravasation, it doesn't really matter what grade of injury you're dealing with. And we'll consider hyperattenuating foci in the spleen, or as I like to call them, the USOs, unidentified splenic objects. These are things that are either active arterial extravasation or contained vascular injury. And it's important to both identify them and differentiate between the two of them. And as Steve has shown you, arterial imaging is vital in terms of identifying identifying the contained vascular injuries particularly. And delayed imaging is crucial for differentiating between vascular extravasation and contained vascular imaging. The delayed imaging in terms of active extravasation also gives you imaging at a second point in time, so it gives you a potential indication at the rate of bleeding. Active extravasation, of course, is not confined. The morphology and size will change over time, and the attenuation of active extravasation is likely to be greater than the aorta on delayed imaging. The pseudoaneurysms or the contained vascular injuries, on the other hand, tend to be contained, and there's no change in morphology or size on delayed imaging, and the attenuation tends to be similar to the aorta on arterial portal venous phase and delayed imaging. And the reason why these unidentified splenic objects are important is here's a very old slide, and you can see here there's an area of abnormality, hyperattenuating focus in the spleen. You can see on the delayed imaging it's not shown, so clearly this is a pseudoaneurysm within the spleen. There's no evidence of active extravasation, so this was not considered for embolization, this was not considered for surgery at the time. The following day, the patient's blood pressure crashed, and you can see here we've got what we used to call delayed rupture of the spleen. It was always considered a problem with splenic injuries. You always had delayed rupture that could occur anything from 2 to 6 days following splenic injury. And of course, there's no such thing as delayed rupture of the spleen effectively. What it is a pseudoaneurysm that didn't get embolized. So that's why identifying these is important. Here we have another splenic injury with an area of increased attenuation just here, active extravasation versus pseudoaneurysm. Delayed imaging confirms that this is a pseudoaneurysm. And this goes for immediate embolization, which will cure the patient. These hyperattenuating foci, as they say, Steve down here a few years ago showed that there was no significant difference in the presence or absence of hyperattenuating foci by splenic injury grade. On the other hand, there was a significant difference in patient management based on the presence or absence of a hyperattenuating focus in the spleen. And not only is there a difference in management based on the presence or absence of one of these foci, but there's a difference in management based on whether the splenic focus represents extravasation or a contained vascular abnormality. And most of the contained vascular injuries are going to be treated with embolization. Active extravasation is a lot more controversial, much more likely to require splenectomy. Not all patients will go for splenectomy. Sometimes they'll try to salvage a spleen with embolization, but for the most part, active extravasation in the spleen is going to end up in splenectomy. And here's another example of a USO in the spleen. Delayed imaging shows change in morphology. It's increased in size. This is active extravasation. Patient gets splenectomy. On occasion, the extravasation is here. You're not going to see this on the arterial phase imaging. And unlike the contained vascular injuries, which tend to show up more prominently on the arterial phase imaging, the active extravasation may not be seen on the arterial phase imaging and may indeed only be on the portal venous phase. In addition to that, another example of a patient, portal venous phase and delayed phase imaging, you don't see any evidence of a significant abnormality. Here's the hyperattenuating focus in the spleen on the arterial phase imaging. This is a pseudoaneurysm, went on to embolization. Another example, patient with a portal venous phase and delayed phase imaging in the spleen and the arterial phase imaging, you can see the contained vascular injury, again requiring embolization. So the impact on management, contained vascular injury needs the arterial phase in addition to the portal venous phase for identification. Active extravasation primarily requires the portal venous phase, and to differentiate between them, very often use delays to help us. And there is a trend towards non-surgical management with conservative versus endovascular therapy, and CT can certainly help to predict those patients that need either embolization or surgical management. We'll move down to the kidneys, and we can see that injuries to the kidneys is significantly less significantly less common. And again, multi-organ injuries. When you have injury to the liver, to the kidneys, you're also going to end up with injuries to the liver and the spleen. But a vast majority of isolated renal injuries are classified as minor, and that's important to remember. There is also a grading system available for renal injuries. Again, it's of little immediate consequence. One of the only impacts it sort of has is on development of scarring. If you end up with renal scarring from trauma, it's a grade 3 injury or higher. Grade 1 and 2 injuries to the spleen, to the kidney will not result in permanent scarring. What's again important in the kidney is the presence or absence of active extravasation of contrast, indicating vascular injury with requiring immediate management, and alternatively, that which results in morbidity, which is the collecting system laceration. And both of these are aided by obtaining delayed imaging. You can see here again there's a variety of hematomas, contusions and lacerations that can affect the kidney. None of these particularly matter in terms of patient management or what you're going to do with them in the absence of direct vascular injury. You can see here a large hematoma, but that'll resolve as long as there's no vascular injury to it. And again, here we have an example where there is active extravasation from the back posterior aspect of the kidney here. You can see here on the coronals. This will require immediate management, and this is the sort of thing that, again, in the kidney will almost always be embolized. Here we have, again, in terms of initial and delayed scans, on the right, there's no evidence of a collecting system injury in this patient. But you will need delayed scans to identify collecting system injury, because an awful lot of this, there's an awful lot of soft tissue or mass or stuff around this. This could be blood, this could be urine, and you can see on delayed imaging there's a huge extravasation or contrast here, suggesting that there is indeed a collecting system injury which requires immediate management. Again, another example with a lot of perinephric fluid, could be blood, could be urine. Delayed imaging shows evidence of active contrast extravasation from the proximal ureter here. And this will require ureteric stenting. If there's any urinoma there, we can drain that, keep the whole thing dry, and believe the collecting system will resolve and cure itself very, very well with that. Again, another example, delayed imaging, showing collecting system injury, which is, again, morbidity, but not mortality. Down into the bladder, we can see here we've a pelvic injury with a lot of fluid here around the bladder. Again, this is a question of, is this blood? Is this urine? We've an area of abnormality here, which we see on bone windows is actually just a fracture. This is a pelvic fracture here as well, so this is not active extravasation. But delayed imaging here shows evidence of free extraperitoneal bladder rupture with fluid around here, indicating that this is bladder rupture. Again, another example of delayed imaging showing ureteric leak, and another one here with a delayed cystogram showing evidence of a bladder leak here. So therefore, if we're going to sum up what we're looking for in the trauma patient, in terms of the kidney, we're looking for that which will result in mortality, active extravasation. You're looking for free contrast, extruding from the vessels, usually treated with endovascular coiling. We're looking for collecting system injury, which are treated with stenting and drainage, and delayed imaging to identify that is vital. What are we looking for in the splenic patient, in the trauma patient with the spleen? We're looking for these unidentified splenic objects, these hyperattenuating foci. Arterial and delayed imaging helps to differentiate between these, and operative and non-operative management options are available. And in terms of the trauma patient for the liver, we're looking at vascular injury and biliary injury. Arterial and delayed imaging help to differentiate active extravasation from contained vascular injury. And the treatment choices here again are embolization for contained vascular injury and surgery, which we will use for active extravasation that's massive and catastrophic. We're looking for bile leaks early as a large association with lacerations, and we're going to consider that we're looking for free bile leaks versus contained bilomas. Thanks very much indeed.
So we will finish up during the last 30 minutes with a focused discussion on important injuries in the abdomen in blunt trauma, bowel, mesentery, and pancreatic trauma. And we've made an effort to try to leave some time at the end for questions, and we hope to have some discussion on techniques. So why are we interested specifically in bowel, mesentery, and pancreas? Well, there's a very large paper published 2 years ago in Journal of Trauma, a retrospective study of over 26,000 scans of over 8 years, and the most commonly missed injuries, important injuries in blunt trauma with multi-detector CT are the bowel and mesentery, pancreas, diaphragm, and the major vessels. And in, again, the 25, 28 minutes, we will focus on the first 3. So bowel trauma is a challenging diagnosis. It's not common, but it is the most easily and commonly missed significant injury in blunt trauma multi-detector CT. About 1 to 2% of all blunt abdominal trauma patients will have a surgical bowel injury found, and it is the leading cause of failed conservative therapy and delayed laparotomy. That is, patients who are admitted to the hospital after sustaining blunt trauma and required a delayed operation during the same hospital stay. The vast majority of those are because of a bowel injury that was missed initially. And it's important because a delay as short as 8 hours is known to be an important cause of morbidity and mortality. So we have really a very short period of time to detect a bowel injury after the patient is admitted to the hospital. And this is a diagnosis that has to be made by the radiologist. Once the patient becomes clinically symptomatic, it's way beyond the 8-hour period, and eventually there will be a significant number of complications ensuing from that initially missed bowel injury. So the signs described on CT that are used to diagnose bowel trauma haven't really changed since the early days of the application of incremental CT in blunt abdominal trauma, and include bowel wall discontinuity. We no longer give extraoral contrast, so we don't find this specific finding, although the literature has proven that the finding of extraluminal oral contrast as the only sign of bowel injury proven in the OR is exceedingly rare. The vast majority of patients will have additional signs that will help us make the diagnosis. Extraluminal air, intramural hematoma, bowel wall thickening, changes in bowel wall enhancement, and pneumatosis are also signs of bowel trauma. And the most sensitive, but unfortunately the least specific sign of bowel trauma is the presence of free intra or retroperitoneal fluid. So while discontinuity is a sign that we don't see often, but this is just one example from a few years ago at our institution, notice there is a large defect in the lesser curvature of the stomach with associated extravascular collection of contrast, obviously massive pneumoperitoneum, a very easily made diagnosis, but a very uncommonly found sign of bowel trauma. Extraluminal gas is very important, and it can be located either within the peritoneal cavity or in the retroperitoneum. And we always recommend our residents to look at the images not only in the soft tissue windows but also in the lung or bone window settings if there's any suspicion that there may be extraluminal gas in the abdominal cavity. The sensitivity is about 50 to 75%. That means that between 1/2 and 3/4 of all patients who are proven to have a significant bowel injury at laparotomy will have pneumoperitoneum or pneumoretroperitoneum on their CT scan. Equally important is the fact that up to 1/2 of patients with proven bowel injury do not have extraluminal gas on their CT examinations. And we also know that the presence of extraluminal gas is not absolutely diagnostic of a hollow viscous injury because there are some sources of false positive results, such as performing a peritoneal lavage, which we no longer do at most institutions. Barotrauma and mechanical ventilation is a very common and important cause of false positive diagnosis of bowel injury leading to pneumoperitoneum. Intraperitoneal bladder ruptures with a catheter can cause intraperitoneal gas. And the most important one from the diagnostic point of view that we see very often causing difficulties in interpretation is the so-called pseudopneumoperitoneum that I will emphasize and illustrate with a few examples. So pneumoperitoneum can be massive and easily diagnosed, as in this particular case. It can also be located in the retroperitoneum in this patient with a proven duodenal injury who also has extraluminal fluid adjacent to the second portion of the duodenum. Or it can present with only small gas collections that are more easily and readily seen on the lung window settings. This patient in addition has a mesenteric hematoma and was proven to have an ileal perforation at laparotomy. But it may be very difficult to detect these often tiny gas collections, and this is a very humbling example of what can go wrong in even a very experienced hands in multi-detector CT of trauma. This patient obviously had a very significant injury. Notice there's a right adrenal hematoma, always associated with a significant mechanism of trauma. There's a gas leak in the chest wall, and in the pelvis, if you notice, there is a very small gas collection that was not detected, and I would argue understandably not detected at the time of the initial interpretation of this exam, but the patient was admitted to the hospital because he had suffered additional injuries, and during the hospital stay developed sepsis, high fever. We repeated a CT examination and noticed there's a very large gas leak and rectal contrast leak that was originating from that initially missed small rectal perforation. So attention to detail in patients who have evidence of significant abdominal injury, such as an abdominal wall hematoma or an adrenal hematoma, should lead us or should increase our suspicion that there may be one of these easily missed important injuries, such as rectal or bowel trauma. We have been saying, all of us, that the 5-minute delayed scans are very important, and they can help even in the diagnosis of bowel trauma, such as in this example, who in the portal venous phase there is questionable focal bowel wall thickening, perhaps some stranding of the associated mesentery, but 5 minutes later the diagnosis becomes unequivocal because we now see a small gas collection that even in retrospect was not visible on the portal venous phase exam. So any patient who, after the evaluation of the portal venous face images on the CT console or the PACS workstation, has any finding that may be suspicious for any injury in the abdomen, warrants a delayed phase series at about 5 to 7 minutes. And as you have seen, we use them to characterize bleeds, to detect collecting system injuries in the kidneys, but also to provide additional information of important findings, such as illustrated with this example. Another very similar patient, questionable wall thickening in the duodenum. Does the patient have an injury? Much easier to make the diagnosis with the 5-minute image that shows a small extraluminal gas collection that, again, was not present, was not visible, even in retrospect, on the initial portal venous face examination. I mentioned already the so-called pseudopneumoperitoneum, which is a not uncommon cause of false positive diagnoses of bowel trauma. It is what it represents is air, gas, trapped between the abdominal wall and the parietal peritoneum, and it can occur with extraperitoneal rectal injuries, rib fractures, or most commonly with patients who have pneumothorax or pneumomediastinum, and the gas leaks into the upper abdomen and gets trapped in the outside of the peritoneal cavity, but inside the abdominal wall. If there's any question that the patient does have pneumoperitoneum, that question needs to be answered immediately, and again, delayed images, decubitus images, a repeat scan should be acquired to determine whether or not it is true pneumoperitoneum. This is a dramatic example of the pseudopneumoperitoneum. Obviously, the patient has massive gas leaks throughout the abdominal and chest wall, and there is pneumoperitoneum without a bowel injury, but there's also gas outside of the peritoneum trapped between the parietal peritoneum and the abdominal wall musculature. This is the so-called pseudopneumoperitoneum. Unfortunately, not all cases are as easily diagnosed as this one. There's another example. Notice there is abundant extraluminal gas, all located outside of the peritoneal cavity. If we focus on the anterior abdominal wall, notice these gas collections, which are linear in appearance, are outside of the parietal peritoneum. This patient does not have an intraperitoneal hollow viscous injury. What he does have is a rectal injury caused by the sacral fracture that allowed gas to leak through the extraperitoneal spaces and the abdominal wall, and finally accumulate in the outside of the parietal peritoneum, very close to the anterior abdominal wall. Let's move on to discuss another very important finding, bowel wall thickening. It is significant if found to be focal, and it could represent either a contusion, a hematoma, or focal ischemia. All of these are surgical lesions. The patient needs a segmental resection and primary anastomosis in the vast majority of small bowel injuries. Whereas patients who have diffuse wall thickening do not have bowel trauma, but rather is a representation of a profound hypovolemia and the so-called shock bowel. So this is the type of finding that should make us very suspicious of bowel injury. Notice there's no extraluminal gas, but there is a very significant focal thickening in this loop of jejunum with associated mesenteric stranding. In trauma, this is blood in the mesentery. The combination of focal bowel wall thickening and mesenteric hematoma, high likelihood of having a significant bowel injury. Regardless of the clinical situation, whether the patient does have abdominal pain or not, this is an indication for laparotomy, and the patient was found to have a perforation at that point. And again, there is no extraluminal gas. Another similar finding, notice there is focal wall thickening, hematoma with blood located in the leaf of the mesentery, in the root of the mesentery of the small bowel, that leads to those thickened loops of bowel. This combination of findings very highly associated with a significant bowel injury, and this patient also was taken to laparotomy and underwent a segmental resection. Notice also that there is a free hemoperitoneum. But we have to look at the context of all the findings. These are two different patients, both with apparent bowel wall thickening in these magnified images. One of them has bowel trauma, the one on the right, because there's associated mesenteric bleeding, hemoperitoneum, whereas the one on the left has absolutely no sign of bowel trauma. This is simply transient peristalsis and spasm, and that will resolve in the delayed scan if one goes on to acquire that series. Let's move on to discuss mesenteric trauma. The CT findings described are mesenteric hematoma, hemoperitoneum with a sentinel clot, active extravasation of contrast, and focal mesenteric infiltration, focal bleeding into the mesentery. The management will vary and will depend on what is the likelihood of there being a bowel injury or ischemia to the bowel secondary to the injured vessel in the mesentery. So multiple mesenteric hematomas, such as in this patient who sustained a significant bowel injury and a significant blunt trauma, notice also the hemoperitoneum, should be an indication for laparotomy because there is a very high likelihood of developing focal ischemia that can eventually lead to a perforation, and this patient underwent a segmental resection and primary anastomosis. This obviously is an indication for operative repair. Well, the size of this hematoma predicts that the vessel that was injured was a large mesenteric branch, and not only does the hematoma need to be evacuated, but very likely a segment will be resected, and again, primary anastomosis performed. And these anastomoses can be done as a primary repair if it's done immediately after the patient is admitted to the hospital. Once the patient has a delayed diagnosis, even if it's 12 or 24 hours, very likely a primary anastomosis will not be possible at that point. Active extravasation of contrast, as shown in this case, is for the most part an indication for laparotomy as well. In some institutions, these may be treated initially with embolization, but there's always a risk of delayed ischemia, perforations, which is obviously the one thing we want to avoid in these patients with possible bowel trauma. And again, as in all patients with injuries shown on the portal venous phase, we go on to acquire the 5-minute delayed scan and take advantage of this image to highlight one point that Steve mentioned in his portion of the talks. Notice how much noisier this image is on the right because we decrease the radiation dose for the 5-minute delayed scan, but it serves the purpose of confirming that this blush in the portal venous phase has increased during the 5 minutes. This patient is actively bleeding into the peritoneal cavity. In fact, notice how the amount of hemoperitoneum has also increased. At this point, the patient is taken to the operating room regardless of the clinical condition. And some more rare findings that are also important to be detected with CT, illustrated in this case. Notice there is a large abdominal wall hematoma. Again, always be very suspicious when you see an abdominal wall hematoma of this size, because that's the patient that has a much higher likelihood of having pancreatic injuries, vascular injuries, or bowel trauma, or mesenteric trauma, such in this case, this patient has a rent in the mesentery of the small bowel that has allowed this very long segment of bowel to migrate outside of the peritoneum and be located very close to the abdominal wall. And this patient luckily was able to be operated on and underwent a repair of the rent, but no bowel resection was necessary. And another uncommon but very important finding, we can see intraluminal bleeding in blunt trauma. And again, that's one of the benefits of not using positive oral contrast. Had we given contrast to this patient, we probably would have missed this very important diagnosis. And the portal venous phase exam, there is a blush of contrast in the lumen of the loops of small bowel. That blush has increased at 5 minutes. Again, notice lower radiation dose, noisier image, and there's also signs of shock bowel in this patient who is actively bleeding. How good is CT? Multi-detector CT, several papers now available. The most recent one from 2013 in Journal of Trauma, 100% sensitivity in the hands of these researchers who performed this retrospective study, and 4 patients had isolated free fluid, which is another topic that I will be talking about momentarily. So what do we do with patients in whom we find only free fluid in our blunt trauma examinations? In the past, males with free fluid would have been considered to have a high likelihood of what we used to call an occult bowel trauma, but we now know that that may not be the case. 2 papers published within 2 years. The first one from our institution The second one from the Medical College of Virginia, both showing very similar findings, large number of male patients in whom the only finding on the blunt trauma CT was a small amount of simple low attenuation fluid isolated to the pelvis, and none of them had a proven bowel injury. None of them required a laparotomy, again, in both series. We think that the cause of this finding of free fluid, small amounts in the abdomen, may be the larger or the more aggressive resuscitation that patients are now undergoing before they arrive to the ER and during the first few instances or minutes of admission to the trauma suites. So this is the type of finding that that I'm describing. Blunt trauma CT showing a small amount of low attenuation, 8 Hounsfield units in this case, limited to the pelvis, we now know is not an indication for laparotomy or laparoscopy. However, if the attenuation is higher, such as this patient, 24 Hounsfield units, then this is not free fluid, this is true hemoperitoneum, and despite this being a female, one has to very carefully look for a potential source of that blood, and we did find a small hepatic laceration that we can now associate with the presence of hemoperitoneum in the pelvis. So what do we do now with these these male patients in whom we see only free fluid in the pelvis? Obviously, we carefully scrutinize the images for potential signs of bowel trauma. And if we don't see anything, then the recommendation is to admit, observe the patient for at least 24 hours if necessary. And that is a practice that has been changing even during the last 1 or 2 years. We would repeat a CT with oral contrast at that point, water soluble, obviously, no later than 12 hours after the initial CT. But no longer do we recommend laparoscopy or laparotomy. So a few examples to illustrate this very point. Initial CT shows no thickening of the duodenum, but there is fluid outlining the contour of the second portion of the duodenum. So does this patient have a bowel injury? Remember, it's a diagnosis that we cannot miss. So the decision is to admit, observe, and we did repeat the CT examination with water-soluble contrast, and notice how all that fluid has disappeared in just 8 hours. Another similar patient, adrenal hematoma, always remember, significant injury. There is mild thickening, but especially some fluid outside of the duodenum. With this finding, the decision was made to admit the patient, observe. Only 6 hours later, the patient already developed some increasing abdominal pain, repeated the CT, and here we have a contained perforation in the duodenal wall, and the patient at that point was operated on. Notice also an abdominal wall hematoma, always a sign that there may be a significant injury within the abdominal cavity. And one final example, this patient who was on the initial CT has questionable thickening, maybe a little bit of stranding. The decision with the surgeons was to admit, observe, repeat the CT 8 hours later. Notice there is already extraluminal gas, no extraluminal oral contrast, but the patient had already some abdominal pain and was taken to the operating room. So let's finish up discussing the second most commonly but important missed injury, that is pancreatic trauma. Again, very uncommon, but very important because it's associated with a 20% mortality, the majority of them occurring within 48 hours, and the majority of the deaths caused by associated injuries leading to acute hemorrhage. But important delayed complications that one needs to remember is if we do not make the diagnosis, fistula, abscesses can develop in patients with missed pancreatic trauma if the main pancreatic duct is injured. The majority of patients with pancreatic trauma will have associated injuries either to the liver, stomach, duodenum, or spleen, such as this patient who has abundant free fluid, a clear laceration in the tail of the pancreas, fluid anterior to the tail, so this patient likely has a main duct injury, but there's also an adrenal hematoma, a splenic contusion. These injuries occur in combination, so if we see splenic injuries, adrenal hematomas, liver injuries, always pay very close attention to the pancreas because that is the one lesion that is not treated conservatively. Those patients do require some sort of intervention. How good is CT for detecting pancreatic trauma? Older studies with thicker slices describe sensitivities of about to 75%. More recent studies, and there's even more recent data now that suggests that the sensitivity approaches 90 to 95%. So how do we classify these injuries? Like it's very similar to other solid parenchymal injury, abdominal organs. Contusions are focal areas of low attenuation in the glandular parenchyma, but we always need to determine whether or not there is pancreatic duct disruption. And we do that by either looking at the CT examination itself or recommending additional studies that will prove definitively whether or not there has been violation of the main duct. And the reason is, if it goes undetected, delayed complications would include abscesses, fistulas, and these patients often require very long hospital stays, and delayed mortality is a very frequent complication of undetected pancreatic trauma. So we can see the duct directly with MDCT, but more often than not, that is still a question that may be unanswered with CT. We look at the depth of the laceration. It's been shown that if the laceration involves more than 50% of the AP diameter of the gland, it has a high association with a main ductal injury. But again, if there's any question, one has to use additional studies. If possible, MRCP can be very helpful, but if there is still a question, ERCP will be the gold standard. Advantages of MRCP are, of course, non-invasive, no radiation, and we use it mostly for surveillance and follow-up of patients who have diagnosed pancreatic trauma seen on the initial or the admission CT examination. With ERCP, not only can we definitively make the diagnosis, but also treat some of these pancreatic duct trauma patients. A few examples: this patient obviously has a young patient, like many of the patients with a pancreatic trauma. The pancreas is compressed between the abdominal wall and the spine, so this is a very typical location for pancreatic injuries. There's a very large hematoma that encompasses the full thickness of the gland. Therefore, this patient almost certainly has an injury of the main duct. The patient was admitted. 5 days later, a very large collection has developed within the gland into the lesser sac, into the major sac of the peritoneal cavity, and the patient underwent stenting, retrograde stenting, as the only therapy, and also some percutaneous drainages, but did not need any laparotomy or resection of the pancreas. Another patient who shortly after the traumatic event had this CT examination that showed not only a laceration but also active extravasation of contrast. Clearly this patient has a transection of the gland that involves the main duct, requires a laparotomy, and that patient did undergo a distal pancreatectomy and primary anastomosis with a loop of bowel. Now, why do we use pancreatic MR in trauma? As I said, it can clarify some questionable findings on the initial CT, but really the main reason we use it is to follow patients who have diagnosed pancreatic injuries and thereby decrease the total amount of radiation delivered to these patients who often end up with very prolonged hospital stays. Good example here, this patient has a laceration that affects the full thickness, but there's no significant free fluid, so the decision was made to perform an MRI. We see the duct, we see the laceration on T2 and T1 weighted images. We followed the patient with MR, and no laparotomy or other intervention was required. Another patient, shortly after admission to the hospital, already there we see a contusion / laceration, full thickness of the gland. Very likely that it does involve the duct, especially because just 1 or 2 hours after the injury already there's abundant fluid, very likely coming from the main pancreatic duct. But before taking the patient to the OR, there was no other indication for laparotomy. We confirmed the findings with MRI, T1, T2 images. Notice the laceration in the same very typical location with contrast, no enhancement in the area of the laceration, but the MRCP images clearly show the site of the transection, and already there's a very slight dilatation of the distal pancreatic duct. At this point, the patient was taken to the OR and a distal pancreatectomy was performed. And the final example, does this patient have or doesn't he have an injury that involves the main duct. Clearly there's a pancreatic trauma. It appears to involve the full thickness of the gland, but it's also very superficial. It's on the upper end of the gland, so maybe the duct is not involved. We did an MRI, and here we have the duct appears intact. There is finding of a pancreatic trauma. The decision was made to not operate on this patient, and no laparotomy was eventually required. Pitfalls, again, remember, it's the second most common important missed injury in blunt abdominal trauma. Equivocal cases that will happen. There will be cases where you're just not certain if there is or isn't an injury. The recommendation is, again, to admit, observe, and repeat the CT examination or perform an MRI during the initial hospital admission. This is an example of how difficult these can be to detect. Notice that this CT examination shows what was interpreted to be a cleft in the pancreas, no stranding around the tail. The patient was admitted because of additional injuries that needed treatment. During the hospital stay, the patient developed abdominal pain. We repeated the CT, and now we have clear signs of a pancreatic injury with stranding around the tail. The patient has so-called traumatic pancreatitis, which is really a laceration that allows leakage of pancreatic fluid into the retroperitoneum. So in summary, my message to you is to search specifically for the lesions that we know are missed commonly in blunt trauma and that are very significant, bowel and pancreas being the most common ones. The three of us emphasize how important it is to do multiphasic exams, which are really critical for maximizing the diagnostic capability of MDCT. Do it rationally. Of course, we have to be aware of radiation, but in trauma, you do not want to cut corners. Saving a series of CT images may lead to a misdiagnosis that eventually requires 5 or 10 additional CTs in the follow-up. And if you have questions about potentially significant injuries on the admission CT, remember what we recommend is admit the patient, observe, and especially in bowel trauma, repeat the CT if necessary, no more than 6 or 8 hours after the first CT exam, and do it with positive water-soluble oral contrast at that point. Thank you very much. So we have 10 minutes, which is what we really wanted to leave for potential questions or any discussion. And if someone has a question, I would ask you to please go to one of the microphones. There's a question here. I'll repeat it. So the question is, do we use a volumen or any neutral or low attenuation contrast? And the answer is we do not. One of the main reasons for, not the only one of the main reasons for not giving oral contrast is the time savings. So we really, in trauma, don't want to wait even 1 hour. So, but that is a very good question. Any other question? So we have a question from one of our virtual attendees. If the AST is not the current grading systems to use for organ injury, are there any classification systems we should be using or just describe vascular injuries? And I'll give my opinion and then allow one of you to answer as well. This really varies from institution to institution. The trend is to not use AST classification, partly because there's always a discussion of whether a patient has a grade 2 or a grade 3 injury, and because we know, as Brian said, that the most important findings are the vascular injuries, and in the case of the liver, the potential for bile leaks. Now, in the case of the spleen specifically, the group of shock trauma in Baltimore has developed what they call a modified classification that is based on CT criteria and specifically incorporates the presence of and the type of vascular injuries such as the ones that we described, and that may be useful if you want to have a classification. At our institution, with the surgeons, we have really abandoned the use of any classification system. Anything to add? Any other question? Okay, please, for those of you still here, remember to fill in your evaluation forms. Thank you very much.